My name is Diana Lawson, and I have been a trauma nurse for 17 years. 11 of those years were spent at Northwestern Memorial Hospital in Chicago, but the 6 before that changed me forever. I served in field hospitals in Afghanistan, where I learned things no nursing textbook ever taught me. I saw young soldiers arrive with injuries that defied imagination, their bodies broken but their will to survive somehow intact. I learned to work with almost nothing, to make split-second decisions that meant life or death, and to use techniques that existed only in military medicine, methods so extreme they would never be approved in civilian hospitals. When I returned to Chicago, I thought I had left that world behind. I rebuilt my life, found peace in routine trauma cases, and convinced myself that the worst was over. My apartment overlooked Lake Michigan, and on quiet mornings I would watch the sunrise and feel grateful for normalcy. But there are some skills you never forget, some instincts that stay buried until the exact moment they are needed. That moment came on a Tuesday in September, and it forced me to face a question I never wanted to answer. When someone has committed unspeakable acts, do they still deserve to be saved? If this story has hooked you so far, subscribe to the channel now, because what comes next will surprise you even more. The morning started like any other. I arrived at 7 in the morning for my shift in the emergency department, grabbed terrible coffee from the break room, and reviewed the night reports with Dr. Marcus Chen, our attending physician. We had 3 beds occupied, a car accident victim being prepped for surgery, an elderly woman with pneumonia, and a teenager who fell skateboarding. Standard stuff. By 9:30, I was restocking supplies when I heard it, a sound that makes every emergency worker freeze. Police sirens. Dozens of them. Then our radios crackled to life with the words that turn your blood cold. Mass casualty incident, active shooter, multiple victims inbound. Within seconds, our department transformed. Dr. Chen activated the disaster protocol, nurses cleared beds, and surgical teams assembled. We had trained for this scenario countless times, running drills and simulations, but nothing prepares you for the real thing. The first ambulance arrived 11 minutes later. A woman in her 30s, shot through the shoulder, then another, and another. 8 victims in the first 20 minutes, all civilians going about their morning, buying coffee, walking to work, living normal lives until a sniper turned downtown Chicago into a war zone. The injuries were eerily precise. Long-distance shots, high-caliber rounds, calculated trajectories. This was not random violence. This was someone with training, someone who knew exactly what they were doing. The emergency room became a battlefield. Blood soaked through our scrubs as we worked frantically to stabilize patients. A young man who had been shot while waiting for the bus kept asking if his dog was okay. He had been walking his golden retriever when the bullet struck. An office worker clutched her briefcase even as we cut away her clothes, as if holding on to that one piece of normalcy could somehow make this nightmare end. I moved between beds with mechanical efficiency, starting IVs, administering pain medication, applying pressure to wounds that would not stop bleeding. But inside, something else was happening. Memories I had locked away were forcing themselves forward. The sound of gunfire in Kandahar, the smell of field hospitals, the faces of soldiers I could not save. Dr. Chen was coordinating with trauma surgeons when Officer Rodriguez from Chicago PD pulled him aside. I was close enough to hear. They had the shooter. He had been cornered after a citywide manhunt and had tried to escape across a rooftop when he fell 3 stories onto concrete. He was critically injured and being transported to our hospital, the closest trauma center. The room erupted. Nurses started shouting that he should be taken somewhere else, that we should refuse treatment, that the families of his victims were in our waiting room. Thank you for staying with me this far. This shows you feel the same way I felt when I lived all of this. So subscribe and hit the bell, because what comes now changes everything. When the paramedics brought him in, I saw something I had not seen in 11 years, not since Afghanistan. The man was strapped to a backboard, his body convulsing with tremors so violent the stretcher shook. His eyes were wide but unfocused, pupils dilated to pinpoints despite the bright lights. His skin had that grayish pale color that signals shock, and he was making sounds, not screams, but this low, repetitive moaning that soldiers make when their nervous system shuts down. Neurogenic shock, battle shock, whatever you want to call it. I had seen it in combat medics who witnessed too much, in young privates after their first firefight, in prisoners of war whose minds broke before their bodies did. It happens when trauma overwhelms every system at once. The brain cannot process the reality, so the body just starts failing. His vitals were crashing, blood pressure 70/40 and dropping, heart rate 160 and climbing, oxygen saturation falling. Without immediate intervention, he would code within minutes. Dr. Chen looked at me, then at the monitors, then back at me. He knew my background. He knew what I had seen. And in that moment, he was asking me a question without words. Every instinct screamed at me to walk away, to let someone else handle this, to let nature take its course. But then my hands were already moving, checking his airway, assessing his injuries, because that is what we do. That is who we are. His injuries were severe but survivable. Compound fracture of the left femur, broken ribs, internal bleeding, head trauma. Under normal circumstances, he would go straight to surgery. But nothing about this was normal. The shock was killing him faster than his injuries. His body was at war with itself, releasing so many stress hormones that his cardiovascular system was collapsing. I had seen this exact presentation in Afghanistan, usually in soldiers trapped under fire for hours, or in surgeons who knew execution was coming. Standard protocols were not working. The IV fluids we were pushing were not raising his blood pressure. The oxygen was not helping his breathing. He needed something else. He needed the protocol. It was a technique developed by military doctors for extreme battlefield trauma, a combination of aggressive pharmacological intervention, forced hypothermia induction, and psychological containment that basically hijacked the nervous system and reset it. It was controversial, ethically gray, and only used when everything else failed. I had seen it performed twice in Kandahar. Once it worked, once it did not. The technique required medications we had but rarely used this way. High-dose sedatives, paralytics, vasopressors in combinations that civilian medicine avoided. It required physically controlling the body's response, while essentially putting the mind into a forced shutdown. If it worked, his system would stabilize. If it did not, I would have hastened his death. Now I want to hear from you. Where are you watching this story from? Write it down in the comments. It is incredible to see people from so many places following stories like this. I looked around the trauma bay. Dr. Chen was watching me, waiting. Two other nurses, Jennifer and Marcus, stood frozen. Through the window I could see family members of the victims in the waiting area. One woman was crying into her phone. Another man sat with his head in his hands. They were waiting to hear if their loved ones would survive, and I was about to save the man who had hurt them. I pulled Dr. Chen aside and explained the protocol in under 30 seconds. His face went through several emotions: surprise, doubt, understanding, and finally grim acceptance. He knew what I was asking to do was extreme, but he also knew I was right. Without this, the man would die before we could get him to an operating room. He nodded once. That was all I needed. I called out orders rapidly. Jennifer got the medications while Marcus prepared the cooling equipment. I established central line access because we needed direct cardiovascular control. Then I pushed the first round of drugs, midazolam to shut down the panic response, followed by rocuronium to paralyze the muscles and stop the tremors, then massive doses of norepinephrine to force his blood vessels to constrict. Within 90 seconds, his body stopped shaking. His vital signs began to stabilize, blood pressure rising, heart rate coming down, oxygen saturation climbing. It was working, but Jennifer was staring at me like I had just committed murder. Marcus would not make eye contact, and I could feel the weight of what I had just done settling onto my shoulders like concrete. He survived the surgery. 6 hours later, he was in the intensive care unit, sedated and intubated but alive. I went home that night and could not sleep. Every time I closed my eyes, I saw the faces, the victims in the emergency room, the shooter trembling on the stretcher, the woman crying in the waiting room. My phone would not stop buzzing. Word had spread about what happened, about the technique I used, about the man I saved. By the next morning, it was everywhere. Local news picked up the story. Social media exploded. Somehow my name leaked. Messages flooded my phone. Some called me a hero for upholding medical ethics, but most called me something else. Traitor, murderer, monster. How could you save him? How could you use special techniques for someone like that? Families of the victims deserved better. You should have let him die. Even colleagues at the hospital started treating me differently. Jennifer requested a schedule change so we would not work together. Marcus avoided the break room when I was there. Dr. Chen defended me publicly, but I could see the doubt in his eyes. A hospital administrator called me in for a meeting about protocols and liability. 3 days after the incident, someone spray-painted "killer nurse" on my apartment building. Someone else left a dead rat on my doorstep. My mother called crying, begging me to leave Chicago and come home to Ohio, but I could not run from this. I had made a choice, and now I had to face it. Then the police investigation revealed something that made everything infinitely worse. The shooter's name was Daniel Garrett, 38 years old, former Army Ranger sniper with 3 tours in Afghanistan. He had returned stateside 7 years ago with severe PTSD, had been dishonorably discharged after threatening an officer, and had fallen through every crack in the veteran support system. His medical records showed he had been treated at 3 different VA hospitals, had been prescribed medications he could not afford, and had tried to get help 4 times in the past 2 years. Each time, he was turned away or put on months-long waiting lists. And then I saw something that stopped my heart. In his military medical file, there was a photo from 2012, Daniel Garrett being treated at a field hospital in Kandahar province. I zoomed in on the image. There, standing in the background wearing blood-stained scrubs and exhausted eyes, was me. I had treated him. 12 years ago, in that desert hospital, I had saved this man's life. I did not remember him specifically. We treated hundreds of soldiers, faces blurred together by exhaustion and trauma. But I had been there. I had stitched his wounds, stabilized his vitals, sent him back into rotation. And years later, broken by war and abandoned by the system, he came back to my emergency room. Some kind of terrible circle closing. I stopped sleeping entirely. Every time I tried, I would see his face on that stretcher, trembling and broken, and wonder if I should have just walked away. I would remember the young soldiers I treated in Afghanistan, boys barely old enough to vote, and wonder how many of them came home to become Daniel Garrett. I would think about the 8 people he shot, about their families, about the woman crying in the waiting room, and question whether my oath to save lives meant anything when saving one life enabled the destruction of others. My therapist asked me a question I could not answer. If I had known who he was, would I still have saved him? I do not know. I honestly do not know. The medical ethics board reviewed my case and concluded I acted within professional standards. The hospital declined to take disciplinary action. Legally, I was protected, but morally, spiritually, that was different. Some colleagues reached out with support, sharing their own impossible situations, reminding me that we do not get to choose who deserves medical care. Others never spoke to me again. Families of the victims filed a lawsuit against the hospital, not against me personally, but I knew I was part of their pain. Daniel Garrett was eventually transferred to a psychiatric prison facility. He would never face trial. His mental state was too fractured. Part of me wanted to visit him, to look him in the eyes and ask why, to ask if he remembered me from Afghanistan, if some part of him recognized that I had saved his life twice, but I never did. I was too afraid of what I might see, or worse, what I might understand. 6 months have passed since that September day. I still work at Northwestern Memorial, though I transferred to the pediatric wing. I needed to remember why I became a nurse, to focus on saving lives that have not yet been destroyed by war and trauma. I still see Dr. Chen sometimes in the hallways. We nod at each other, but rarely talk. Some things are too heavy for words. I learned something about myself through all of this. The oath I took is not conditional. It does not ask me to judge who deserves help and who does not. It asks me to heal, regardless of the cost to my own peace of mind. But I also learned that doing the right thing does not always feel right. Sometimes it feels like betrayal. Sometimes it feels like complicity. And you live with that weight forever. The families of the victims will never forgive me. Part of me will never forgive myself. But another part, the part that watched too many soldiers die in Afghan field hospitals, that saw what happens when we give up on broken people, that part knows I would do it again. Because the alternative is becoming something I cannot live with. Someone who decides that some lives matter less than others. Someone who lets people die because they are difficult, or controversial, or hated. That is not medicine. That is not healing. That is just revenge. And if you stayed with me until this final moment, write the word duty to prove you heard the whole story, and to show that you understand why some choices haunt us forever, even when they are the right ones. What do you think? Did I make the right call? Leave your honest opinion in the comments. Subscribe to see more stories that challenge everything you think you know, and watch the next video. Because these real experiences reveal what truly happens when healthcare professionals face impossible moral dilemmas.